In this section, Principles of Pharmacology 3, we'll be primarily discussing different types of receptors and their downstream signaling. In this section, Principles of Pharmacology 3, we'll be talking mostly about drug receptors and their second messenger system. The way that a drug will interact with a cell is determined by where the receptor is located and what the second messenger systems and enzymes linked to that system are. Some medications will bind to an intracellular receptor, and these include steroids and vitamin D. Other medications will bind directly to a membrane receptor, which may be coupled to an ion channel, or to a, for example, G protein, which will activate second messenger systems, and then certain enzymes such as kinases or other transporters. Here's a cartoon of different types of drug receptors. The first example would be that of a receptor similar to the beta-adrenergic receptor, which is a membrane receptor. A drug here would be like the beta blocker, which is able to bind to the receptor and inactivate it. The next example will be that similar to the GABA-A receptor, which is actually a chloride channel that can also bind to a medication, such as a benzodiazepine. Another example of a drug receptor that can bind to a medication would be a voltage-gated ion channel, such as a voltage-gated sodium channel. Certain antiarrhythmics will bind to the channel and prevent the passage of sodium through that channel. Other drugs, such as phosphodiesterase inhibitors, will inhibit enzymes that are located inside cells, and this would be another example of an intracellular drug receptor. When looking at intracellular receptors, the major class of these would be the nuclear hormone receptors. When the drug or the hormone binds to the receptor, it changes the conformation of the protein receptor, and this protein receptor will generally work by modifying the expression of certain genes. Therefore, these receptors are also transcription factors. These receptors include a large variety of receptors for different steroidal compounds, such as thyroid hormone, estrogen, testosterone, and vitamin D. Other important drugs and hormones in this category include the retinoids, progesterone, mineralocorticoids, and glucocorticoids. Again, in this cartoon, we see the molecule 17-beta-estradiol, which is able, because of its lipophilic properties, to go simply through the cell membrane, bind it to its nuclear estrogen receptor, and then cause changes in transcription in that cell. Other membrane receptors are directly coupled to ion channels, or may actually be the ion channel. These receptors will contain channels that regulate the flow of ions through the membrane. And this is very important for certain cells such as muscle and nerve tissue. There are no second messengers usually that are involved at these receptors, and many drugs will mimic or antagonize the action of endogenous ligands at these receptors. Some very important examples of this would be the nicotinic acetylcholine receptor. This acetylcholine receptor at the neuromuscular junction and at autonomic ganglia is actually an ion channel. Other examples would be voltage-gated sodium and potassium channels, which are very important in neurons and muscle cells for generating action potentials. Another example, which we already talked about, is the GABA-A receptor, which is actually a chloride channel, which is a target of sedative hypnotic drugs such as benzodiazepines and general anesthetics. The nicotinic acetylcholine receptor, which we briefly talked about, is a cation selective ion channel, whereas the GABA-A receptor is a chloride sensitive or chloride selective ion channel. Some second messenger systems which are downstream of the drug receptor involves first and foremost G proteins or GTP binding proteins. Certain receptors are able to either activate adenylyl cyclase, which is the enzyme that causes production of cyclic AMP, or inhibit adenylyl cyclase based on which specific G protein is activated by that receptor. It's also important to remember that cyclic AMP is able to have downstream effects, including activation of certain kinases and other downstream effects. This is what's referred to as second messenger systems. Here's an example of the dopamine a 1A receptor, which after binding dopamine, the receptor is able to activate a G protein, which is a GTP binding protein. If the G protein is GS, then it activates adenylyl cyclase, which is able to activate the conversion of ATP to cyclic AMP, which can go on to have other effects, XYZ, in the cell. G protein coupled receptors are generally referred to as serpentine, and if we can go back briefly, you can see that this receptor here actually spans the membrane similar to a snake. That's why it's referred to as serpentine. Most G protein coupled receptors have 7 transmembrane spanning domains. However, not all G protein coupled receptors have 7 domains. These G protein coupled receptors are very important drug targets. Some of them include the muscarinic receptor, the alpha and beta adrenergic receptor, and a few of the serotonin receptor subtypes are G protein coupled. Cyclic GMP is a second messenger, which is very important for vasodilation of vascular smooth muscle. Nitric oxide is able to increase the production of cyclic GMP. Nitric oxide is generally released from endothelial cells, and nitric oxide will activate guanylyl cyclase, which is the enzyme that increases cyclic GMP production. Nitrate medications, such as nitroglycerin and sodium nitroprusside, directly activate guanylyl cyclase, increasing cyclic GMP, which causes vasodilation of vascular smooth muscle. Certain receptors are also linked to certain kinases. Kinases are enzymes that cause phosphorylation of proteins, meaning the enzyme will actually put a phosphate group onto other proteins. The insulin receptor is actually a tyrosine kinase, meaning that the receptor itself, when it binds insulin, has the ability to put a phosphate group onto tyrosines of both itself and other molecules. So therefore, this insulin receptor, after being activated, will promote phosphorylation of multiple proteins, including proteins X, Y, and Z. The insulin receptor only has a single transmembrane helix, as opposed to other G protein coupled receptors, which have more like 5 or 7 transmembrane domains. There are also many enzymes in the body that are drug targets. Some important ones to remember are, for example, acetylcholinesterase, which breaks down acetylcholine. It is the drug target for cholinesterase inhibitors such as neostigmine. ACE, which is the angiotensin converting enzyme, is the target for ACE inhibitors such as captopril. Carbonic anhydrase, an enzyme that causes sodium bicarbonate to be converted into carbon dioxide and water, can be inhibited by certain medications such as acetazolamide. The sodium-potassium ATPase, which generates the resting potential of most cells, is inhibited by digoxin. And viral reverse transcriptase, though it's a foreign enzyme, is the target of many reverse transcriptase inhibiting drugs for HIV. Transporters are membrane proteins found on the surface of cells that are involved in the reuptake of neurotransmitters. The activity of these transporters is to decrease the concentration of the neurotransmitter in the synaptic cleft, and this allows for on-off distinction in the nerve cleft. Dopamine transporters will actually decrease the concentration of dopamine in the central nervous system. These are inhibited by drugs like cocaine and amphetamine, which increase the concentration of dopamine in the synaptic cleft in the central nervous system. Other medications, such as tricyclic antidepressants and cocaine as well, will increase the concentration of norepinephrine by blocking the transporter, or the reuptake. And then SSRIs, such as fluoxetine, are able to inhibit the serotonin transporter, increasing the concentration of serotonin in the synaptic cleft. Affinity is a term that basically defines the tightness of the drug as it binds to its receptor. Kd is a value that each drug has for a certain receptor, and it is defined as the concentration at which 50% of that drug is bound to the receptor. The potency of the drug is defined as the quantity of the drug required that is able to achieve a desired effect. It is influenced by affinity, and it is summarized by the ED50 or the EC50. EC50 is the concentration, ED50 is the dose of a drug which produces 50% of an effect that you consider a maximal effect of that drug. And that effect can be many things. For example, for antihypertensive medications, it could be blood pressure control. And efficacy is the maximal effect that any drug can achieve that's not based on the concentration or dose of the drug. As you can see, as dose increases on the x-axis, effect of that drug will also increase. The efficacy is defined as this level, meaning no matter how much of the drug you give, you can only achieve this level of efficacy. A more potent drug would be A, as compared to B and C. B and C are able to reach the same efficacy level, but A can do it at... Here's another chart that compares effect versus concentration. And remember, the effect can be many things based on which drug you're talking about. For example, the biological effect could be killing off of bacteria in the case of antibiotics, stopping seizures in the case of antiepileptics. And as you can see, as the concentration of the drug increases, drug A is more potent than drug B. An agonist is considered to be a drug that activates any receptor. It doesn't matter whether the receptor itself causes an inhibitory response or an activatory response. An agonist is simply a drug that activates a receptor. Full agonists would produce a maximal response from that receptor, whereas partial agonists will bind to receptor, and they'll bind to the same receptor site usually as a full agonist, but will elicit a smaller maximal effect. They're by definition less efficacious than full agonists. And depending upon the situation in which they're used, they may appear to act as an agonist or an antagonist. Some examples of partial agonists include buprenorphine at the mu-opioid receptor and pindolol at the beta-1 adrenergic receptor. What I mean by the situation is that for a given receptor R, if there's a lot of agonists around, A, that can all bind to the receptor, then if you add a partial agonist here, and it's getting in the way of the agonist binding the receptor, this partial agonist may actually appear to be an antagonist, because its effect at receptor R is lower than the agonist's. But if there's not a lot of agonist around, then adding this partial agonist will actually appear to be an agonal response instead of an antagonal response. As you can see, partial agonists are less effective than full agonists over time. Antagonists for a receptor do not cause any response on the receptor. Antagonists are molecules or drugs that block the effect of agonists. And there's different type of antagonism for different receptors. Some antagonism is competitive, some is non-competitive. Competitive antagonism means that on a receptor, you'll have an agonist and an antagonist. And the antagonist binds to the same point on the receptor that the agonist does. Therefore, these two compete with each other for the same binding site. A non-competitive antagonist will bind to a different part on the receptor, and therefore is not competing with the agonist or binding sites. There are other types of antagonism that don't involve binding sites, and that would be chemical antagonism and physiologic antagonism, and we'll talk more about that. Again, competitive antagonism involves competition with agonists for the same binding site. Competitive antagonism, it's very important to remember that by increasing the dose of the agonist, you can reverse the antagonism. An example of this would be atropine at the muscarinic acetylcholine receptor and propranolol at the beta-adrenergic receptor. Non-competitive antagonists, again, bind to a different site. These are also known as allosteric inhibitors of a receptor. Remember that these drugs always decrease efficacy of agonists, and sometimes will also decrease the potency of agonists. Remember that because these antagonists do not bind to the same binding site as the agonists, they cannot be overcome by high concentration of agonists. There are only a few clinically important examples for this. One example is ketamine, which binds to the NMDA glutamate receptor. Here's another curve that shows effect over time in the log of the concentration of the agonist. And as you can see, as you give the agonist, your EC50 is right here, because you've achieved 50% of your maximal effect here. And the concentration required to do that is right here on the x-axis. As you give a competitive antagonist, you shift the curve to the right. You've decreased the potency of the agonist. However, giving more agonist will eventually allow you to reach the same efficacy point as if you were giving the agonist alone. By giving a non-competitive antagonist, however, you decrease the efficacy, because by giving more and more agonist, you're still not able to kick off that non-competitive antagonist. Irreversible antagonism, also known as suicide antagonism, involves a drug that covalently modifies a receptor, which permanently inhibits that receptor. And the action of this can only be overcome by synthesis of new receptors. The most important examples for this are phenoxybenzamine, which is an antagonist at alpha-1 and alpha-2 receptors, and aspirin, which will irreversibly inhibit cyclooxygenase 1 and 2 in platelets. Therefore, the body must make new platelets to overcome aspirin. This is why we don't give aspirin directly before surgeries, because patients will not be able to clot very well. Chemical antagonism involves molecules being antagonized by other molecules other than drugs. So, for example, heavy metal chelators such as tetracycline plus calcium causes antagonism, because calcium inhibits the ability of the tetracycline to bind to its receptor, which would be the bacterial ribosome. Protamine, which is a heparin inhibitor, chemically binds to heparin to form an inactive complex. Physiologic antagonism is a more complex idea that involves activation at one receptor, which is antagonized by another action at a different receptor. So a perfect example of this would be the acetylcholine receptor and the beta-adrenergic receptor. Norepinephrine binding to the beta receptor will increase heart rate. However, acetylcholine binding to the muscarinic receptor will block this response by decreasing heart rate. Two different receptors causing physiologic antagonism. It's also very important to compare the therapeutic dose-response curve to the toxicity dose response curve. This will give you, for any drug, a therapeutic index. Every drug has its own therapeutic index. And this is basically a ratio of the toxic effect to the therapeutic effect. In animal experiments, it's defined as the LD50, or the lethal dose at 50%, divided by the effective dose at 50%. In humans, it's usually defined as a toxic dose, meaning a dose at which 50% of patients experience some form of toxicity, divided by the effective dose, meaning the dose at which 50% of patients receive the maximal effect. As you can see on this curve, we have the same drug in the green and the blue curves. This dose in milligrams at this point is the ED50. This blue curve is the death curve, meaning the drug at a certain concentration will cause a certain amount of death or toxicity in the patient. The dose at which you see 50% of patients experiencing death would be the LD50. The LD50 divided by the ED50 is equal to the therapeutic index. In this drug, it's equal to 4. What this means is that not all drugs have a straightforward concentration response curve. Going back to this slide, you can see that as you increase the dose of a medication, the effect will also go up. An example of when this does not take place is the drug nortriptyline and its effect on treatment of depression. As you increase your dose of nortriptyline, you will increase the ability of the drug to fight depression. However, over time, it's shown that patients will not improve at higher levels of nortriptyline. It's not understood why this occurs. The point is that you don't see a maximal effect that goes to infinity with these patients. You actually see a decrease in their improvement of depression. Let's talk for a minute about the FDA. The Food and Drug Administration in the United States regulates the efficacy and safety of drugs, but not of nutritional supplements and herbal remedies. The FDA is able to remove nutritional supplements if it can prove that there is clear evidence of harm. With regard to drug development and the formulation of new medications, there are multiple steps involved for the approval of a new medication. The steps of drug development are outlined in this slide. First of all, medications are tested in animals. These are called the preclinical animal studies. After this, healthy volunteers are given the medication in phase 1 trials. The question for phase 1 trials are the drugs safe for volunteers? One exception to this is chemotherapy medications, which is initially tested in patients that have cancer. Phase 2 trials are efficacy trials. And this is the first time the drug is given, in most cases, to patients that actually have the disease that the drug is meant to treat. Phase 3 trials are very large trials. These trials ask how well does the drug work and what are the common side effects. These are often double-blinded randomized trials in which half the patients receive the drug and half receive a placebo. These are very important and very expensive for medications to become approved. Phase 4 trials usually occur after the medication has been approved, and these will follow the drug out many years to see what the long-term side effects of the medication are. Some medications, because of their abuse potential, are regulated highly, and they're divided into 5 schedules, Schedule 1 through Schedule 5. Schedule 1 medications have a very high potential for abuse. These are medications that do not have accepted medical use in the United States. And they include medications such as heroin, LSD, mescaline, peyote, and methaqualone. Many of these medications at one point used to be legal. However, they have been shown to be very dangerous. Schedule 2 medications have a high potential for abuse, but they can be prescribed under certain conditions by specially licensed physicians These medications include morphine, methadone, meperidine, amphetamines, secobarbital, and methylphenidate. Schedule 3 medication include certain medications that may be abused but have very legitimate medical effects, such as anabolic steroids, which can be used in patients that have some type of growth retardation, as well as other opioids and barbiturates, and dronabinol, which is a derivative of marijuana. Schedule 4 medications include drugs that have a low potential for abuse but can lead to dependence, and they include phenobarbital, chloral hydrate, and other medications. Schedule 5 medications are generally medications that can be sold without a prescription, and then most medications fall under this category. This is the final slide in this section. This concludes our Principles of Pharmacology section. Next, we'll be moving on to more specific drugs and their receptors.